bit worried about coming onto the stage with all the national policy stuff first, but actually it's been quite a good run through because I'm a psychiatrist. That's why I've got no suit on. And following on the mental health is very good. And of course, dementia often falls between two stools about physical and mental health. And pain particularly. We have no health without mental health. I hope by the end of this you'll see that there's no mental health without physical health as well. This is an important topic. So I think this is a sort of specific example maybe that some people might want to get their teeth into to test out some of the mechanisms in the new public health system and for Healthwatch to pick up for various reasons that I'll explain. So what goes wrong in dementia? I mean, this is the classical stuff, the psychological stuff, the context changes for the person, they get difficult understanding. Society has views about dementia which are sometimes helpful, sometimes not. But the things that people forget is communication drops off. I mean, the big thing that happens in dementia is you lose, as you get on, as you go through the dementia, you lose the ability to communicate verbally, but you still can communicate non-verbally. You lose the ability to look after yourself and become reliant on others, and then swallowing, delirium and pain are towards the end of the disease. Now, this is very much about what happens towards the end of the disease rather than the beginning of the disease. I know public health is very concerned about finding everyone with dementia, but I worry that we sometimes forget there's nearly 1 million people out there who already have it and have other needs as well as just the detection. Those symptoms are actually no different from many other terminal conditions. But I don't think dementia ever gets thought of as a terminal condition in the later stages, hence some of the problems that go wrong. Now, pain, there are two issues. One's under recognition, which I'll talk about, and then under treatment. It's fairly obvious, and I think if you pick many diseases, people will go through the same two headings. But if you look at pain in community-dwelling people with dementia, that's the spread, slight, moderate and severe. But at the bottom, a third of patients and half the carers had a mini mental state of 16, which is roughly halfway through the disease process. A third and a half would say that there is pain present right now. If you look at nursing home residents, so these would be more advanced, and look at pain over the last 7 days, the prevalence is half have painful symptoms, and a quarter have pain daily. Well, I can tell you, not many are on any pain relief. And as the study shows, the less able you are to communicate, the less likely you are to have anyone notice that you're in pain. If you look at death in nursing homes, a lot of people are expected to have a life expectancy of less than 6 months. A small number of less than 6 months. And 3/4 of those will die within those 6 months. But if you look at the list of what people die from or contributory causes, pressure sores, pain, and shortness of breath, that's quite a lot, and these patients are not perceived as terminal, so they don't get onto any relief or pathways. And there's a scale that's been developed to look at that called the Mini Suffering State Examination. I'm not going to read the points, but that's what's measured using a scale. And if you look at people with dementia dying in nursing homes, the level of suffering at the time of death, is high in over nearly 2/3. So we're not in a very good position in terms of how we treat people with dementia, particularly once they get into care homes. So what is the issue? Well, there's acute pain, which normally is a symptom of disease and has a function. If you pick up something that's hot, you tend to drop it. There's a reason for acute pain. But chronic pain, the chronic pain that exists beyond the acute phase and can be a dysfunction of the nervous system or a chronic condition, that doesn't actually serve a function. And the third pain, the pain that always gets forgotten, this is a very small study, but what happens with most people with dementia when they get to a nursing home is they never see the dentist again. And I guess most dentists would say none of us go enough either, but in 21 nursing home residents, when the dentist looked at these people, 2/3 had what they perceived could be a painful condition, whereas the geriatricians didn't. So, just getting dental care into care homes might be an interesting option. If you look at the pain conditions across the board, so on the left, the mini-mental state is deemed as no dementia, on the right, Alzheimer's disease. You can see that the common pain conditions, arthritis, post-surgery, cancer, neuropathic pain, there isn't really any difference between the Alzheimer's population and the normal population who can express themselves in terms of the conditions that they have. Oops. But if you look at the analgesia, in terms of acute pain, there's no difference. So if you're in acute pain with dementia, you're probably going to get treated because you're making the same sort of fuss as a person without dementia. But chronic pain is significantly undertreated. So that's partly because, as I've already said, the person's going to report it less, but also it's not going to be detected. So acute pain looks to be preserved in Alzheimer's disease. There seems to be this dissociation in pain, and we don't understand with people that can't express how the pain's affected them, whether it's different or worse. But we do know it's there. Is it just the community? No. This is a study from 2006 looking at acute hospitals, and this is 455 patients who had osteoarthritis. And if you look at these are paracetamol equivalents, and if you look at the number of people that had treatment, then on the left you've got the lowest cognitive score, and on the right the highest. So there's a dose response again, showing that in hospital you get less pain relief according to how you can communicate. So again, a training issue for hospitals. There are pain scales. I'm not going to get into details on pain scales. This is just an example of one. They're not very, very long, and most older people, when they go into hospital, get a raft of scales. So adding one in would not be a great hardship, and I think Joanne's going to talk about specific initiatives around that. But I think one of the most important things, and going back to the no health without mental health, and making assumptions about people who have one label and not looking for other things, that's a list of behavioural pain indicators. So there's the grimacing, that's fine, but moaning, groaning, calling out, fidgeting, pacing, aggressive, resistive, refusing food, crying. That's a list of common symptoms found and noted as behavioural disturbances in dementia. And there is a huge overlap. Now, one of the big public health challenges is reducing antipsychotics in nursing homes. A lot of people get antipsychotics for those behaviours. A lot of people don't get examined to see if they've got pain. There was an American study, small numbers and not been replicated, an American study looking at pain in nursing homes, where 1/3 of the people screaming out had small bone fractures, where they got caught in cot sides or broken a toe. It's very rare if someone has those behaviours that someone comes out and does a proper examination. It's normally said they're symptoms of dementia, because us psychiatrists have got a different list. They're symptoms of dementia, therefore you just need to do what we've done in the past. And I think there's a real challenge there, and if you really want to start reducing antipsychotic prescribing, apart from reducing the prevalence, which is reviewing drugs, it might be that the incidence isn't always for the right condition. It might be for the right reasons and symptoms, but not the right condition. So that's a very quick few examples of what the problems might be. A quick summary is that it's common. It manifests differently in different stages. And like dementia, all symptoms manifest differently in a different person. So I like the global, the global issues and the personal solution, because that doesn't happen always with people with dementia. The assessment is difficult because of the similarity of symptoms and signs, so we need to make people more aware of it. And the management is frequently suboptimal. So the challenge, in terms of public health, is to continue to look holistically at people in terms of all possible explanations for distress, not going for the obvious, and provide appropriate and effective pain management and comfort to patients, including people that are challenging and who are vulnerable and unable to speak for themselves. That's my challenge, and now I think Joanne's going to come and give you an example of London practice to try and address some of that.
I'm Jo, and I'm a nurse. I'm currently working on a training program at UCL Partners, and I thought one of the things we could do today as the second part of this lecture was just use a real person to illustrate the experience of pain for somebody with dementia when it isn't managed properly. So I'm going to introduce you to B. B was 87 years old and she had vascular dementia. She had a gangrenous right foot after a hospital admission, and she was refusing to eat. She was biting and she was pushing and she was scratching and screaming, all those sort of symptoms that Roger was talking about, which often get treated with antipsychotics. But she was also losing weight. She just was losing lots and lots of weight. And she was referred over to a palliative care project team that were working on a project around palliative care and dementia. And when they looked at the hospital notes, this is what they found. The team, the care home team had actually spoken to the medical team and said they were worried about the fact that she was behaving like this and maybe she was in pain. And they decided she wasn't. This was her foot. So, I don't know about you, but I kind of think that would probably be quite painful myself. But they didn't feel pain relief was indicated. They felt that she appeared comfortable, even though she was biting and screaming. And so eventually, after a little bit of persuasion, they were persuaded to prescribe her some paracetamol tablets. She was unable to localize or explain her pain. She wasn't able to identify, why something was hurting. She'd forget about it, so when you went up to her and she was lying still, you could have a nice little chat and it would be fine. But the moment she was moved, she'd shout, and she was actually shouting out, "It's sore, go away, leave me alone." Kind of a bit of a hint there, I think. She was unable to swallow the paracetamol. A lot of people with dementia, particularly advanced dementia, develop swallowing problems. A lot of them have distrust of tablets and don't really understand what they're for, and might be quite reluctant to take them. And so she was refusing the paracetamol because for some reason she didn't want to take them and she wasn't confident to swallow them. And in spite of this, she was left in that situation for 6 weeks. So 6 weeks of being moved around and calling and shouting out that she was sore, and she still didn't get any pain relief. And that's an experience of one person. That's an experience which is quite commonplace for people with dementia, and that's what we've really got to try and address. There was a study done which is just about to be published, and it was based in hospitals. And I'm going to just whip through it because Roger's kind of talked about the statistics, and some of it's the same, so I'm sorry for being a bit repetitive. But what it did show was that 65% of the patients actually had pain on movement. And so obviously pain is prevalent. We know pain is prevalent for people with dementia in these situations. It also showed that in 22% it was persistent, and it was persistent for the whole admission. These patients in this study were observed for their whole admission, so people were going back every day and observing how they were getting on. And that was in spite of the fact analgesia had been prescribed to 75% of them. So something went wrong between the fact that somebody obviously recognised there was an issue with pain, but they still were in pain. So the choice of analgesia, or perhaps the mode of delivery of the analgesia, was wrong, because for some reason, a bit like being her paracetamol, they were still in pain. So what was going wrong there? The other thing that it showed, and again, very much supports what Roger was saying, is that pain was strongly and consistently associated with extreme behaviours, and particularly aggression and anxiety. And this is something that has been a really hard message to get over, that if there are extreme behaviours, often pain is something to do with it, and pain needs to be excluded before we dive in with antipsychotic prescribing or anything else. It just needs to be asked. And I've got a very tacky slide here just to illustrate that, which isn't going to work. Don't blame it on the dementia. I told you it was lowbrow. But that is a really, really important message. It's a question we have to always ask, is before thinking it's just a symptom, a behavioural symptom of dementia, we need to ask ourselves if something else is going on and there's an unmet need, or there's pain. So how can we address this? We need to increase understanding and awareness about it and link behaviour and pain, as I said. We also, I think it's really important to make the point, even with the story of B, that actually everybody wanted to do the right thing. The healthcare and social care staff want to look after people the right way. They want to care properly, but sometimes they don't have the tools to do it. And part of what we need to do, I think, and what we need to think about is how we can equip people to assess pain, understand pain, and be able to deal with it. We need to embed the right pain assessments into our clinical interactions, and Roger showed a particular type. There are loads and loads out there. I can't remember how many there are, and some of them are really long and some of them are quite short. But people need to have access to them. They need to understand they're available, and they are actually some of them are quite accurate, are reasonably accurate, and they're all observational. So we need to think about that. We need to get pain on the agenda whenever we talk about dementia care. It should be part of our dialogue when we're talking about the needs of someone with dementia. And then we need to get the management right. It's no good thinking, oh dear, this poor person's in pain. I'm going to give them these great big tablets that they can't swallow, and then I've sorted the problem. People don't take things for lots of reasons, as we know. I looked after a man at the Royal Free called Dr. Bill, who refused his pain relief for days and days and days and wouldn't get out of bed. And when we actually asked him why, it turned out that he'd been a rheumatologist and he didn't believe in paracetamol because he thought it was really rubbish and he wanted something else. And he had a perfectly valid reason for refusing, but no one had thought to ask him because he also had dementia. So thinking about our management and how we deliver it, and how we deliver it in a way that works for the individual. Training, really important. I was going to say it only needs 30 minutes, but obviously Roger's example, it actually only needs 10 minutes, so we could do it in a really quick, short time. But we do need to train people to think about using observational pain assessment tools, or just observation. I was talking to somebody in palliative care recently, a senior registrar, and she was saying it's very interesting because in palliative care they quite often don't use observational sort of pain assessment tools because it's so embedded in their practice to think about pain, so it's just something they're observing for all the time and they're reporting on. And I thought, wouldn't that be a brilliant thing if we could get to that point where we don't actually need to have another tool, we just do it automatically as part of what we deliver for people. Any dialogue on behaviour must ask the question, is the person in pain, at the beginning, right at the beginning, before we do anything else. That question should be answered and should be investigated. If people want to deliver pain training, there's some really good stuff out there. And one thing that I was involved in the development of, which is really good, really easy, and set up for anyone to use, are the NHS London dementia modules, which are available. And basically, there's a managing pain one, which it gives you instructions on delivering it, and it has all the scenarios, and it's a really good message. So there's stuff out there available for anybody to use to help improve pain management. Currently what I'm doing is I'm involved in a project with the Local Education Training Board and UCL partners around training 12,000 general staff in dementia awareness by March, so not a particularly big ask there. But what we've done is we've weaseled pain in through the side entrance because we've got lots of people who are actually quite specialist in dementia care in our patch, like mental health services, dementia services, prison services, day centres. So for all of them, we're actually delivering pain awareness training, and that's actually gone down really well. It's been a really well-received suggestion. So there's lots of ways of sneaking it in there when you're doing other things, and I'd implore all of you to sneak it in somewhere if you can. Getting pain on the agenda generally, it's there on the agenda with lots of other life-limiting diseases, but for some reason dementia kind of missed out, probably as Roger said, because it's it's been in a sort of mental health silo for a long time, so people have forgotten a little bit that there's sort of physical health issues as well. The assessment and management of potential pain needs to be an intrinsic part of the way we plan care and sort of health and social care for someone with dementia. And when we discuss quality, and when we're looking at, we're talking about quality indicators and what provision, we should be asking the question, what provision is in place to assess and manage pain in these patients? It should be there as one of our questions. And we should measure, how well people are doing based on how well they're thinking about that. Because you can't really have well-being when somebody's in terrible pain. Do we lack a bit of imagination when we come to managing pain? I think we probably do, because not everything, as I've said, has to be in tablet form. There's lots of other non-pharmacological ways of managing pain. We had a fantastic massage project at the Royal Free Hospital where all our inpatients were given, with dementia, were given massage, and it was fantastically effective at getting them moving, making them feel more comfortable, reducing the amount of pain relief they were using. And so there are lots of ways we can be quite imaginative in our management. Finding comfortable ways to do things, not being rigidly fixed about the way we're going to behave, the way we're going to position someone when we do something or where we're going to put them, making it comfortable for the individual. Also giving a person actually time and autonomy. Did anybody actually stop moving B when she asked them to stop moving? Probably not. We need to actually listen to our patients and listen to what they're saying, because quite often they are able to tell us when they're uncomfortable and they're in pain, and so it's about giving them the time to be able to express that. And that's it. It's a very brief, literally just finished, and Roger and I will be at the NAP stand, which is I think stand number 1, until the next break if anyone wants to talk to us a little bit more about pain. Thank you very much.